Hi guys, good evening, good evening, good evening. I'm Dr. Sandeep, your surgery faculty. Today is our first session on the compounding series, right? So as we have discussed it, that every day we'll be posting one question, and from that one question we'll make it into a week. That is, after 7 questions are posted, we'll come back live on YouTube and then do a session where we'll be discussing answers to all the questions, right? This is the first time we're trying a YouTube live. If the link is with some reasons not able to access, do let us know. Okay. Now, I'm hoping you would have joined. All right, so let's begin. We'll be starting with the first question that we have posted. That was the day one's question that we had. The first question that we have posted was this. Okay. So what does the question says? The question tells that we have a 47-year-old male arrived to the emergency room with an altered mental status and hematemesis that began a day ago. Okay, one day before is the history. Right, the history is only one day before. Right. Okay. He has a 22 years history of alcoholism with the last binge just 2 weeks back. Ultrasound revealed an altered echo texture of the liver and the mild portal vein was dilated. CT brain was normal, thank God. He was started on IV pantoprazole as well as antiemetics. What should be the next? Now, this is our catch point. What is the next step in the management? Now, when you talk about what is the next step in the management, you need to understand what is the case that we're dealing with, right? Now, if you look at all the pickup or the important points that have been provided here, if you look at all the important points that are given here, it is we have number one, 47-year-old male. We have the 47-year-old male is there. He is a known alcoholic. He is a known alcoholic. Right, that was a long history. And then you have history of hematemesis. So patient has presented with hematemesis, right? So we had all these points are there. Male, that is there. Then you have altered mental status with hematemesis. So hematemesis with altered mental status, right? CT is normal, so there is no head injury. Echo texture revealed the altered echo texture. That is, ultrasound says there is abnormality in the liver. Ultrasound says there's abnormality in liver, right? What else are the important key points, right? So the patient was started, CT was normal. So I know that the patient does not have, patient persona does not have any traumatic or brain associated component. So now I have a 47-year-old female, known alcoholic, hematemesis present, altered echo texture in the liver. So with the altered echo texture in the liver, I can say there could be liver cirrhosis. Now, how am I saying liver cirrhosis? I came to the diagnosis of liver cirrhosis because the patient has alcohol history. So, the alcoholic with known liver cirrhosis, and liver cirrhosis causing hematemesis is probably due to portal hypertension. It is probably because of the portal hypertension. Now, the question is, what is portal hypertension? Now, we all know the portal hypertension is where the portal pressure. So, the normal portal pressure is going to be 1 to 5 millimeters of mercury. It is 1 to 5 millimeters of mercury. When do you call it as pre-portal hypertension? Pre-portal hypertension is described when the pressure is between 6 to 9 millimeters of mercury. It is 6 to 9 millimeters of mercury. When would you say the patient is having portal hypertension? We say portal hypertension when it is more than or equal to 10 millimeters of mercury. When do you have bleeding due to portal hypertension? That is bleeding from esophageal varices. So bleeding due to portal hypertension will occur when the pressure exceeds more than or equal to 12 millimeters of mercury, and once the pressure hits 14 and above, it is going to increase the mortality as well. So now I know the patient is a known case of liver cirrhosis that is secondary to alcohol. So my current diagnosis, portal hypertension. Why will the portal hypertension will have bleed? In portal hypertension, the most common clinical presentation. The most common clinical presentation. Can anybody would like to answer? What is the most common clinical presentation of portal hypertension? This is your bleeding esophageal varices. This is going to be a bleeding esophageal varices, right? Now, in the bleeding esophageal varices, what is the algorithm that we usually follow, right? So whenever a patient of bleeding esophageal varices is going to present to us, right? So you have the bleeding esophageal varices secondary to portal hypertension. How do you manage it? So this is the question based upon the management of bleeding esophageal varices. Bleeding esophageal varices. Now, any patient of bleeding esophageal varices is going to present to you with upper GI bleed. Is going to present to you with upper GI bleed. The patient is going to present to us with upper GI bleed. So when I say upper GI bleed, we all should also know what is the clinical presentation of upper GI bleed, right? So if anybody would like to contribute, what are the clinical features of upper GI bleed? The upper GI bleed is going to present to you with hematemesis. It is going to present to you with hematemesis. It is going to present to you with anemia due to blood loss. Along with that, it will also present to you as melena. The blood that goes up will also come down, so there will be hematemesis, there will be anemia, there will be melena as well. Now, what is the minimum amount of blood required to cause melena? That's also a previous exam question. The minimum amount of blood required. The minimum amount of blood required to cause melena. Is going to be 60 ml. To cause melena, it is going to be 60 ml, right? So minimum amount of blood required to cause melena, it is going to be 60 ml. So bleeding esophageal varices will present you with upper GI bleed. Now, how would you like to counter it? So any patient who presents to you with upper GI bleed, now the step number 1, it is to secure 2 large IV cannula. Secure 2 large IV cannula, preferably a 16 gauge needle. If it is not available, we can go ahead with 18 gauge needle. Now, along with that, start the patient on IV fluids because resuscitation is predominantly important, and the preferred fluid is going to be ringer lactate when compared to normal saline. Secure 2 large IV cannula, start the patient on IV fluids and do resuscitation. Now, once you have done the resuscitation, now step number 2 is going to be assessment. Now in the assessment, as you are doing so, remember your systolic blood pressure should be maintained more than or equal to 80 millimeters of mercury, and make sure that your heart rate is kept less than 100 beats per minute, and your hemoglobin level should be more than or equal to 8 milligram percent. This is the target assessment that you have. Now once you have looked at the assessment protocol, you start the patient on IV fluids. After starting the IV fluids, I can have 2 components where the bleeding is come to a halt. So 2 contexts where there is continues to bleed, and another one where the bleeding has come to a halt, right? So bleeding has come to halt. Now in this assessment criteria, you have to make sure that you also try to assess the status of shock, right? If the patient is below 8 milligram percent of hemoglobin, or there is less than 80 millimeters of mercury pressure, that also indicates that you need to go ahead with blood transfusion also, right? Hi Kaleem, good evening, right? Now if the bleeding continues to happen, now this is the first attempt. If the bleeding is still happening, then I would like to give a somatostatin analog, that is injection of octreotide. I'd go ahead with injection of octreotide. It is a somatostatin analog. You can also give terlipressin. These are your vasoactive drugs, right? Now, once you have given these drugs, I'll have a reassessment of whether the bleeding continues to happen or bleeding stops. Here we will see if the bleeding continues to happen or if the bleeding stops. Or if the bleeding stops. Now, if bleeding continues to happen, or this is where you have to take things into control, because if patient continues to bleed, the patient will die. So I know there's an upper GI bleed, probably because of esophageal varices. If bleeding continues to happen, then I have to go ahead with balloon tamponade effect. You have to go ahead with balloon tamponade. Now, what is a balloon tamponade is, I'm going to put a balloon that is called as the Sangastkane. We'll go ahead with Sangastkane Blakemore tube. We'll go ahead with Sangastkane Blakemore tube, which is also called as an standard SBT tube. Sangastkane Blakemore, or also called as an SBT tube. Now, the question that are usually asked according, or with relevance to an SBT tube, is where would you put it, how would you inflate it, what is used to inflate it, what is the advantage, and all that. So we'll talk about it. See? So this is your esophagus and stomach, and this is where you have your esophageal varices, usually in the lower 1/3 of the esophagus. You will also have the fundus varices also. So this Sangastkane Blakemore tube that you're going to insert, the Blakemore tube is going to be put from, it's like a nasogastric tube only, it is going to be positioned here. Now, once you're put here, now you're going to inflate the balloon. There are two balloons. One is going to be an esophageal balloon, and you're going to inflate the esophageal balloon. Another one is going to be a gastric balloon, and you're going to inflate the gastric balloon. Now, as you inflate both the balloons, you can see these balloons are going to exert pressure onto the lateral wall. Now, as they exert pressure onto the lateral wall, they will compress the varices, and once they compress the varices, the bleeding will come to an halt, and this is the basic mechanism of your balloon tamponade mechanics, right? Now, usually they ask you is that with respect to esophageal balloon, what are we going to use to inflate it? Remember, esophageal balloon is inflated with air, and the pressure that is to be maintained at 40 millimeters of mercury, then you should stop. On the other hand, you have the gastric balloon. Now, when you inflate the gastric balloon, again, I'm going to use air, and here the volume is going to be 300 ml of air has to be inflated in order to create adequate amount of pressure. Now, all the intelligent people are thinking, why we shouldn't be using normal saline, ringer lactate, or distilled water to inflate it, because you might think no, water will create more force, but the problem is it will also create more weight. So if the water or fluid is going to be filled up in these balloons, the balloons are going to get heavy and the balloons are going to drift down. ठीक है, तो अगर आप इन बलून्स में हवा भर दोगे, पानी भर दोगे, फ्लूइड भर दोगे, बलून भारी हो जाएगा तो नीचे आ जाएगा. अगर नीचे आ जाएगा तो मुझे प्रेशर चाहिए ईसोफेगस और स्टमक में. अगर आप यहाँ पे प्रेशर प्रोवाइड ही नहीं करा पा रहे हो, इफ यू आर नॉट एबल टू एक्सर्ट इनफ अमाउंट ऑफ प्रेशर हियर, तब तो ये बंद ही नहीं होगा. तो इसलिए जब एयर से रखोगे, एयर से क्या होगा, बलून फ्लोट करेगा, एंड देन इट विल एक्सर्ट प्रेशर ऑन टू द लैटरल वॉल्स, तो ब्लीडिंग तो रुक जाएगी. यही तो हमको चाहिए था. एक और आपके INI-CT में एक क्वेश्चन है, दैट इज दैट इफ द बलून इज इन्फ्लेटेड, when it should be deflated. Remember, balloon must be deflated. The balloon must be deflated every 12th hourly. It must be deflated every 12th hourly. Now, why it is important is, if you don't deflate the balloon and keep it like that only, what is going to happen? It is going to cause pressure-induced necrosis. Now, this is going to result in pressure-induced necrosis. Okay? So, balloon must be deflated every 12th hourly to prevent this activity is done to prevent pressure-induced necrosis. To prevent pressure-induced necrosis. Okay? So this is with respect to balloon tamponade. Now, once the balloon tamponade is done, the bleeding will come to a halt. Right? So once the bleeding stops by hook or crook, now we are ready for step number 3. Now, in the step number 3, I'm going to take the patient for gastric lavage. In the gastric lavage, we're doing the gastric lavage because, I want to assess where the source of the bleeding is. So you have to rinse the entire mucosal surface because it's stained by blood. I don't want that to be, dirty when I put my endoscope. So what are you going to do? I'm going to do a gastric lavage, and the gastric lavage must and should be done with what are you going to use? Not distilled water, because if you use more amount of distilled water, it is going to get absorbed. As it is going to get absorbed into the circulation, it will cause dilutional hyponatremia. I don't want that to happen. To prevent dilutional hyponatremia, क्या करोगे? हम यूज करेंगे नॉर्मल सलाइन. ठीक है, अब नॉर्मल सलाइन यूज तो कर लिया. सवाल ये है कि नॉर्मल सलाइन का टेम्परेचर क्या होगा? व्हाट विल बी द टेम्परेचर ऑफ द नॉर्मल सलाइन दैट यू गोइंग टू यूज फॉर गैस्ट्रिक लवाज? रिमेंबर, cold use nahi karna hai. Don't use cold, because cold you think it is causing vasoconstriction, but the other problem with the cold normal saline lavage, it causes transient platelet dysfunction, which will cause exacerbation bleeding. Warm normal saline, it is going to result in what? It is going to result in vasodilation. More amount of blood will flow. Again, viruses will rebleed. I don't want that to happen. So normal saline should be used at room temperature. It should be used at room temperature. Once the gastric lavage is done, the step number 4 is to evaluate with upper GI endoscopy. On an upper GI endoscopy, if there is presence of esophageal varices, you have to confirm. Now, once the esophageal varices are confirmed, we go to step number 5. The step number 5 is what we call it as EVL. EVL stands for endoscopic variceal ligation. It is called as the endoscopic variceal ligation. Now, this endoscopic variceal ligation is a fancy term to tell you that we are doing banding of the esophageal varices. This is a fancy term to tell you that you are doing we are doing banding of esophageal varices. We're doing banding of the esophageal varices. As simple as that. Okay. Now, once the EVL is done, you tell the patient it's all fine. The patient goes back home. Now, what if he comes back with the re-bleeding? Right after EVL, if it re-bleeds, we call it the first episode. If there's a first episode of re-bleeding, in a first episode of re-bleeding, what will you do? What will you do? आपने थोड़ा रीब्लीड करा है तो आप बोलोगे कोई गल नहीं है, हम रिपीट एंडोस्कोपिक वायरसियल लाइगेशन करेंगे. अगर ईवीएल करने के बाद पेशेंट फिर रीब्लीड के साथ आता है, राइट, इधर वो अकेला नहीं आएगा, पूरा गांव साथ लेके आएगा, एंड यू ट्राई टू फाइंड वेयर आर यू. सो इफ देयर इज अ सेकंड एपिसोड ऑफ rebleeding, so I've done 2 times EVL and then it rebled. If there's a second episode of rebleeding, this is what we call it as refractory variceal bleeding. This is what we call as refractory variceal bleeding. और refractory variceal bleeding के लिए current management is going to be shunt surgery, right? So the current management is going to be intervention. तो intervention के नाम पे आप करोगे tips. Tips is going to be transjugular. It is going to be transjugular intrahepatic. Transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portosystemic shunt is to be placed. Okay, so this is the entire algorithm that you have to follow, as simple as that. तो हमारे क्वेश्चन में सवाल ये था कि what will be your next step? ठीक है, the patient came, everything is done. So what is the next step? What is the next step? The next step is going to secure the IV line, start the fluids, and that is going to be our option number D. So here the answer to our first day question is D for Delhi. I hope you have gotten it right. Do not make such mistakes. ठीक है. Now, antibiotics का कोई role नहीं है. Antibiotics are only given once you have a foci of infection. Otherwise, there's no role for antibiotics. Now, would you like to do a liver biopsy? Remember, whenever a patient is having a cirrhotic liver, in a cirrhotic liver, there will be deranged coagulation profile. Now, if there is a deranged coagulation profile and if you have not confirmed it and you go, poke on, let's say, biopsy forceps or the biopsy needle into the liver, it will bleed. And when it bleeds, if it does not stop, it can be life-threatening, especially cirrhotic liver associated with what? Ascites. Biopsy should never be done. Why? Because normally, whenever you do a liver biopsy, even if the, if it bleeds, that will cause an hematoma, and because it is going to be occupied by 9, 10, 11 ribs, what is going to happen? That hematoma is going to occupy that space and create a tamponade effect between the ribs as well as the liver, and the bleeding will stop. If it is ascites, it is going to be filled with fluid all around, no, and it bleeds, it will continue to bleed. There is no pressure effect or temperament effect there. The patient will cause a lot of problems. So never do a blind biopsy. Now perform an endoscope to look at the varices. This is only done once the patient is stabilized, and it is not yet. As I told you, to do an endoscopy, first stabilize the patient, stop the bleed, do a lavage, then endoscopy. The endoscopy तो बहुत पीछे की बात है ना, तो ये तो आंसर हो ही नहीं सकता. So answer here is going to be D for Delhi. As simple as that. लेट्स गो टू डे नंबर 2. सेकेंड डे पे क्या सवाल पूछा था? सेकेंड डे पे सवाल आया था, क्या सवाल था? सवाल था 21-year-old फीमेल, ठीक है, complains of neck swelling, difficulty in swallowing, hoarseness of voice. Radiological evaluation revealed a mass compressing the trachea. Biopsy showed arrangement of nests with amyloid deposits. What is the origin? Remember, presence of amyloid in a thyroid tissue indicates presence of medullary cancer thyroid. It indicates medullary cancer thyroid. अब ये जो medullary cancer thyroid है, ये originate कहाँ से होता है? Now if you take this, a representation of the thyroid gland. So this is one lobe, this is another lobe, right? You will see there will be a lot of lobules which are going to be present, which are created by these fibrous septa which is present. And within these are what we call as the lobules within the thyroid gland. Within these, you will see these are the functional cells which are called as the thyroid follicles, now which are going to produce T3 and T4, right? Now around these thyroid follicles you have these specialized cells, and these specialized cells are what we call it as parafollicular C cells. These specialized cells are what we call it as parafollicular C cells. Now, whenever the malignancy in the thyroid gland is going to arise, it is going to arise either from the follicles or it is going to arise from the parafollicles, right? Now, if the malignancy arises from follicles, we call it as follicular origin tumors. We call it as the follicular origin tumors. So, when talk about follicular origin, I can further divide them into well differentiated and poorly differentiated. Now, when you talk about well differentiated and poorly differentiated, the best example of well differentiated tumors are papillary cancer thyroid as well as follicular cancer thyroid. Whereas poorly differentiated tumor, it is going to be your anaplastic cancer. It is going to be your anaplastic cancer. On the other hand, you see this is your parafollicular C cells. This is your parafollicular C cells. Now they call as C cells because they produce calcitonin, and if the tumor arises from the parafollicular C cells, this would be called as medullary cancer thyroid. This will be called as medullary cancer thyroid. The other one is going to be thyroid lymphoma, as simple as that. Now coming back to our original question, so they're asking what is the origin. So the question is emphasizing to tell us the origin of the cell. Now, is it a follicular one? No. The follicular one is going to be papillary follicular anaplastic cancer, not medullary. Yes, the answer is going to be parafollicular C cells. Hurthel cells and Ashkenazi cells, they are seen in Hashimoto's. They're seen in Hashimoto's thyroiditis. They're seen in the Hashimoto's thyroiditis, right? Now, Hashimoto's thyroiditis, again, if they ask you a couple of questions, how can they make your life difficult? For a Hashimoto's thyroiditis, they will ask you, number one, it is a thyroid inflammation. Now, what type of inflammation? It is an example of chronic inflammation. It is an example of a chronic inflammation, right? Now, what is the cause? It is an autoimmune disorder. It is an autoimmune disorder. Now, in Hashimoto's thyroiditis, the antibodies are formed. They are your anti-thyroperoxidase antibody. They are anti-thyroperoxidase antibody, which works with activation of CD4 cells going into CD8 cells and causing cell destruction. Right now, on the histopathology, on an HP, they are supposed to have these cells, which are called as the Ashkenazi cells. Right now, your pathologists are going to create a little bit hype around it, and they'll say, what do you find in Ashkenazi cells, right? Now, the findings on an HP for an Ashkenazi cells, it is going to have presence of pink granular eosinophils, or the pink granular eosinophilic cytoplasm. They'll have pink granular eosinophilic cytoplasm. They will have a lymphocytic infiltration. they will have presence of lymphocytic infiltrations are noticed, and it is associated with follicular damage. It is associated with the follicular damage, which is characteristic of Hashimoto's thyroiditis, right? So all these are going to be associated with that of Hashimoto's thyroiditis. Okay? Now, so the current answer for the question for medullary cancer thyroid, it is going to arise from parafollicular C cells. Okay? So that's our day 2 question. Going on to our day 3. Now, what do we have on day 3, right? So day 3, we jumped into GIT. I have a 23-year-old female complains of difficulty in swallowing food. Weight loss is present from last 4 months. She also complains about regurgitation of undigested food and halitosis. Barium swallow was performed and the image is given. What is the likely diagnosis? So when you look at all the important pickup points, we have female. There is dysphagia. That is difficulty in swallowing is there. It is associated with weight loss. That means dysphagia is so severe that the appetite of the patient. So when I say the weight loss here is probably because of reduced appetite. And then there is regurgitation. Then there is regurgitation. There is presence of regurgitation and there is presence of halitosis. Right? And then when you look at the radiograph, again radiograph is quite self-explanatory. It looks as if a bird is poking with its beak, and there's smooth filling defect, and this is your bird beak appearance. So on a radiograph, we have the bird beak sign. On a radiograph, we have the bird beak sign. Now, every single thing that is present here is screaming out loud and clear that we are talking about a condition which is called as Achalasia cardia. We are screaming out loud and clear that we are talking about a condition which is called as the Achalasia cardia. Now, a couple of important things about Achalasia cardia. No? Okay, everything else is there, female, dysphagia and all that. But here, remember, dysphagia will be more for liquids. It will be more for liquids when compared to solids, right? Another thing, it is going to have a progressive dysphagia. This is going to have a progressive dysphagia. Again, a very, very important point from the exam perspective. Along with progressive dysphagia, it will also be associated with pulmonary symptoms. Now, these pulmonary symptoms are usually because of aspiration. Now, the food that is present in the lower part of the esophagus, which is not able to revert back. Now, what is going to happen? Now, as the patient is not able to swallow, when it reverts back, when it is going to regurgitate, some amount of food can go into trachea, result in pulmonary symptom, that is going to be your aspiration pneumonitis. So, this progressive dysphagia associated pulmonary symptoms, and it is because of loss of inhibitory neurons. This is because of loss of inhibitory neurons. There is progressive dysphagia, there is presence of pulmonary symptoms, loss of inhibitory neurons, all these are present. Okay? Now, on the other hand, just for the sake of understanding, right, if I just add, if at all they say there is regurgitation of previous day food particle, then the answer would change. Now, regurgitation of previous day food particle is seen in what? It is seen in Zenker's diverticulum. So any diverticular disorder, no, it is seen in Zenker's diverticulum. Now, when you talk about halitosis can be seen in both Achalasia cardia as well as it can also be seen in Zenker's diverticulum. It can also be seen in Zenker's diverticulum, right? So in Zenker's diverticulum, there will be regurgitation of previous day food particle associated halitosis. Here, regurgitation of food is there. Okay? All these are the important pickup points. So what is the likely diagnosis? We have got a diagnosis. It is going to be Achalasia cardia. It cannot be esophageal carcinoma because in esophageal carcinoma, number one, we will have presence of apple core sign, that is on a radiograph. There will be presence of dysphagia, but dysphagia is usually quite late. And here it will be only for solids if at all exists. Later on it can go into liquids, unlike Achalasia cardia. This will also be an example of a progressive dysphagia. This will also be an example of progressive dysphagia. So there is apple core sign, there is dysphagia, solids for liquids. More for solids when compared to liquids, there will be progressive dysphagia. It will be associated with significant weight loss. Now that significant weight loss is any weight loss which is more than 10% of the body weight. Along with that, the patient will also have presence of upper GI bleed. That is because of hypervascularity of the tumor, as simple as that, right? So again here, none of them is going into favor, and it is more common in males. When we talk about esophageal cancers, no, they're more common in males when compared to females. Achalasia cardia is more common in females when compared to males. So everything is going in an opposite direction. Here, as you can say, achalasia dysphagia is more for liquids. Here it is going to be more for solids. Here you have the bird beak sign. It is the apple core sign. They can also say pencil tip also. Either say the bird beak or they can use the word pencil tip appearance. Anything remains the same, right? Now, can it be an esophageal varices? No. In esophageal varices, the patient's presentation will be not of dysphagia. In fact, here in esophageal varices, patient will present to you with upper GI bleed, which I have already discussed earlier. Can it be an esophageal stricture? Now, in an esophageal stricture, no. In an esophageal stricture, patient will present to you with dysphagia. Now, here dysphagia will be more for solids when compared to liquids. It is going to be more for solids when compared to liquids. It is unlikely to have weight loss, regurgitation of halitosis, and your radiograph will not have this presentation. It will have filling defect. See? So all these are going to be your important components. So here the the answer to the question is going to be achalasia cardia, right? So day 3, it is achalasia cardia. Now, just for the sake of understanding, just in the context of achalasia cardia, the investigation of choice for achalasia cardia is going to be manometry. For any mutilated disorder, the investigation remains as manometry, right? Now, remember, on a manometry, we have something called as integrated relaxation pressure. If it is more than or equal to 15 millimeters of mercury, right, with failed peristalsis. This is consistent for achalasia cardia, right? Now, in the achalasia cardia, when we talk about the management, the first line management is going to be a medical management. In the medical management, you'll start with calcium channel blockers, nitrates and all that. If it doesn't work, you have to go with surgery. The second line management is surgery, and the surgery of choice is going to be Heller-Dor myotomy. Now, what is this Heller-Dor myotomy? It is actually a modified fundoplication. Okay? It's a modified Heller's procedure. So here you do a Heller's cardiomyotomy. That means I'm going to involve the cardia of the stomach with Dor partial fundoplication. Now, this partial fundoplication is done to prevent GRD. This is done to prevent GRD. So, Heller's cardiomyotomy with Dor's partial fundoplication. Okay? So, this is your day 3. Now, day 4, this is for you to recognize the instrument. It says that we have given you an instrument. The instrument shown below are used for which of the following procedure? Now, this you can see here at the end. You can see there is a small cap and there's a huge tube and a fenestration. There is a stillet and there is a passer and there's a guide wire here, right? All these goes in favor of an instrument that is called as PEG. PEG stands for percutaneous. It is a percutaneous endoscopic gastrostomy. It is a percutaneous endoscopic gastrostomy, right? So this PEG has 2 techniques also, where you can have pull and push technique. So either you can go with a pull technique or a push technique. Either you can go ahead with a pull technique or you can go ahead with the push technique. Okay? So here the answer is going to be percutaneous endoscopic gastrostomy. So you should be able to know the other few instrument drains also, which is going to be in our exam. Number 1, this is your corrugated. This is your corrugated rubber drain, because it's orange in color, right? Just below this, this is your corrugated silicon drain. This is your corrugated silicon drain. This happens to be your Foley's catheter. This is your 3-ways Foley's catheter. Now this 3-ways Foley's catheter, the 3-ways Foley's catheter is used for bladder irrigation. This is going to be for bladder irrigation, right? This is your Penrose drain. This is your Penrose drain. This happens to be your Romovac drain. This happens to be a Romovac drain. This happens to be your T-tube used for CBD exploration. And the last one, this is your pigtail. Right? So all these are image-based questions that is anticipated for our exam as well. Right? Now going into day 5. So what do you have on day 5? On day 5, I have a 35-year-old male. An episode of LOC is there. There's loss of consciousness. Subsequent to a head injury from a bike accident. Upon awakening, he begins experiencing severe headache is present. Nausea is there. He appears drowsy at a GCS of 10, which of one of his pupil is dilated and non-responsive. Following NCCT, head was taken, given below. What is the management done in this case? Now you can see on an NCCT you have this presentation. You have this presentation. What is this? So there is a clot that is present, and this is in this shape. This is what we call it as the biconvex opacity, or also called as lenticular opacity. So after a road traffic accident with drop in GCS suddenly, and then on a CT you have biconvex or a lenticular opacity, this is a case of extradural hemorrhage. EDH, the most common source of bleeding. The most common source of bleeding in an extradural hemorrhage, it is going to be what? Most common, it is going to be middle meningeal artery. This is going to be the middle meningeal artery. That is the most common source of bleeding. So you have the extradural hemorrhage. The most common source of bleeding is going to be your middle meningeal artery. Now patient will have signs and symptoms of raised intracranial pressure, but more importantly there will be presence of lucid interval. So when I say signs and raised ICT, there will be headache, nausea, vomiting. Sorry, no nausea. There will be vomiting. Obviously, it is a non-projectile. I mean, it's a projectile vomiting. There is no nausea because of head injury, raised ICT. So patient is going to have headache. There will be vomiting. There will be post-traumatic seizures, blurring of vision. All these will be present, indicating the patient has raised ICT. Lucid interval is a period of consciousness between two unconscious episodes. Is what we call it as lucid interval. So it's a case of EDH. The most common source is middle meningeal artery. It will present to you with raised ICT and lucid interval. Investigation of choice is going to be NCCT. Remember, another characteristic presentation will see ipsilateral pupil dilation. There will be ipsilateral pupillary dilation with contralateral hemiparesis. Contralateral hemiparesis, right? Now, when you talk about the management, no, if there is an emergency, where there is no CT available, emergency if CT is unavailable. If CT is unavailable, then the answer is going to be burr hole surgery, which outside the pupil is dilated. As a definitive management, it is going to be craniotomy. It is going to be craniotomy, right? So here the question is, what is the management done in this case? Anticoagulation to prevent any further clots? No, it is a rapid expansor. GCS is dropping. Observe him. You cannot observe because GCS is dropping. Osmotic diuresis to decrease the ICT. Remember, mannitol is avoided in extradural hemorrhage, right? Whereas mannitol can be given in subdural hemorrhage. Whereas the mannitol is given in subdural hemorrhage. What is the concept behind it? Now, mannitol basically, it causes diuresis, right? It basically reduces the cerebral edema. Now, imagine here the bleeding in the extradural hemorrhage is because of an artery, and it creates a massive clot. That clot itself exerts pressure on the bleeding blood vessel for the blood to stop or bleeding to stop, right? That is a tamponade effect. Now that temporal effect is created between the skull bone and the brain parenchyma, right? Now, if I use mannitol, what will happen? The fluid from this, the brain is going to drain. The CSF will become less. The capacity of the fluid in the brain will also reduce. The brain will shrink in size. If brain shrinks in size, will it allow it to bleed more, less, or bleed less? Obviously, providing more space, no, there will be suddenly more bleed also. So mannitol, as it causes decrease in cerebral edema, right, or it will cause decrease in the fluid capacity of the brain shrinks in size, allowing the hematoma to expand more, which will cause more deteriorating effect, and that will also create or result in brain herniation. You don't want that to happen. So hence mannitol is best avoided in extradural hemorrhage. So this is wrong. So urgent surgical evacuation, that is on an emergency basis, you can consider for burr hole surgery. You can consider for burr hole surgery, right? So that is going to be on your day 5. Clear? Chalo. So day 6, it's a very simple question. Don't make mistakes on this. What is the most common hernia in female? No matter it is male, female, everyone, it is your indirect inguinal hernia is the most common hernia in males as well as females. It is more common hernia in both males as well as females, right? Now remember, femoral hernia is more common in females. I'm not saying it is the most common in females, so it is more common in females when compared to males, right? So in incidence, femoral hernia will be more commonly seen in females, but overall most common hernia in females will still remain as your indirect inguinal hernia only. So last one is going to be day 7's question. So on a day 7, what did we have? In a day 7, on a day 7, we had which of the following is not done during the primary survey in the trauma. Remember the goal for the primary survey. The goal for primary survey. The goal for the primary survey is to rule out. It is to rule out any immediate life-threatening injuries. To rule out any immediate life-threatening injury, and if required, intervention. If required, intervention should be considered, and this is the goal of the primary survey. Now, based upon this goal, we have the protocol, that is your A, B, C, D, E. We all know it. A is airway with cervical spine stabilization. B is your breathing and ventilation. C is circulation, hemorrhage control. Disability elimination, expose and examine. As simple as that. Now, when you apply this, in which of the following is not done? So you have to see which is not done. Are you going to do CT or not? Chest X-ray or not done. Chest X-ray in trauma is usually done to rule out pneumothorax, or I can say tension or an open pneumothorax, right? Now, both of them are immediate life-threatening injuries. How do you know it's an immediate life-threatening injury, whether the patient is having pneumothorax or not? By getting a chest X-ray. So yes, I will get a chest X-ray done. Intubation, yes, whenever there is an airway injury or an airway compromise, I have to intubate. That is a part of the primary survey, should be performed. ICD, would you like to put? Yes, if there is presence of hemothorax, right, or if there is presence of pneumothorax, immediately to relieve both of this, I have to perform an ICD insertion, and that is a life-saving procedure. So yes, ICD would be considered. Would you like to do an NCCT brain? Remember, in a primary assessment where you're talking about disability limitation, disability limitation is done with the help of two things. Number one, I'm going to go ahead with pupil assessment, and number two, GCS. There is no role of CT here. Now, as I told you, if the GCS is dropping and the patient is deteriorating fast post head injury, and you're talking about extradural hemorrhage, you see ipsilateral pupillary dilation with contralateral hemiparesis, whichever side the pupil is dilated, you do a burr hole immediately. You don't need to wait for CT to happen if there's an emergency situation. So yes, NCCT brain is not required, and it is not a part of your primary survey. So answer which is not to be done here, it is going to be option C only, that is 4, right? So these is how you will assess your questions, right? So the objective of doing the compounding series is to give a quick recap on how to approach a question, look at the options, and start developing that problem solving ability, right? As you continue to do more and more questions, you'll get more and more better at it, right? So do not forget to do so. Hi Dhruv, good evening, right? So So the first session of your compounding series, I've concluded it. So we have done all the 7 questions we have posted for the last 1 week. We'll come back again in the next week in another 7 questions. I want you to follow all the questions that are posted. I hope everybody knows where we're doing it. On the Instagram, we have our page. This is called as the surgery guy. Right. So this is by my name only. That is Dr. Sandeep Seeram Reddy. Just go find it, follow it. You have the same Telegram group is also on the same name. If you're not on Insta, you can go and follow on the Telegram group. It is Dr. Sandeep Seeram Reddy. If you have any questions, any queries, feel free to reach out. So thank you so much for joining today. We'll resume back next week. We'll announce it again the same time. Probably we'll do it on the Monday only, where you have that Monday motivation keeps on kicking for you at the same time, right? So thank you so much. If you have any questions, any queries, you know where to reach out. I've explained all 7 questions. If you want to have more explanation or more types, you know, a little bit of more data, feel free to write us. We'll do that as well. Hi, Tushar. Right. So for all those who have been live, thank you so much for joining, and we'll resume back next week, right? Thank you. Bye. Good night. Take care. We have BLS now. Okay. Whoever wants to join, 9 o'clock, we'll start our BLS, right? So see you down there for BLS. Bye bye.